Good afternoon, everyone. I'm Dr. Hassan Azzain, cardiology fellow in the second year, Kuwait Board of Cardiology. So I'm so glad to be here to participate in the GIS conference this year, and it's a truly pleasure to share my presentation with you. So my case is about a 37-year-old police officer. He's previously healthy. He has no history of diabetes, hypertension, smoking, or any cardiac risk factor. Patient presented with acute, typical chest pain while on his way to work. ECG at the ER showed inferior ST elevation, so accordingly the patient was shifted directly to the cath lab for the primary PCI. And this is a coronary angio. As you can see here, there is a huge aneurysmal dilatation in the RCA. So when I injected the RCA, so my consultant asked me, where you inject the contrast? Is it in is it RCA or where you inject the contrast? So there's a huge dilatation in the RCA with the thrombus distal the dilatation, causing subtotal occlusion of the RCA. So the left system, as we can see here, there is no significant lesion, just ectatic vessels, ectatic left system. So we did thrombus aspiration for the RCA. Is a good result and TIMI3 flow. There is a good result after the thrombus aspiration. So we kept the patient on the CCU on the IV terifipran, DAPT, and heparin. I remember this patient, he was a young patient, just he wanted to leave the hospital. This is his first time in the hospital, and he was asking for discharge. The next day, the second day, exactly after 24 hours, in the early morning, the patient developed severe chest pain followed by the cardiac arrest. He was resuscitated for 8 minutes with the successful return of spontaneous circulation. We intubated him, and we shifted him directly to the cath lab. Again, coronary angio showed the same picture like the previous one, total occlusion of the RCA just distal to the area of aneurysm. We did a thrombus aspiration again, and we put the intra-aortic balloon pump due to hemodynamical, for hemodynamical support. Over the next 3 years, the patient gradually improved, was extubated, and all the mechanical and pharmacological supports were successfully discontinued. So we did echo later on. It showed that ejection fraction is about 40%. We did for the possible underlying cause, we did autoimmune screening, full vasculitic screening, and viral workup. All results were negative. We did a CT angio for the neck, brain, and visceral vessels, which reveals there is no other aneurysm or arterial dilatation. So we have the heart team discussion to decide what about the next step of management. The surgeons was willing to do bypass surgery, but the patient refused. So after thorough discussion between the heart team and the patient, the final decision was to continue anticoagulation and to do relook angio after 3 months. Here we choose the warfarin because our hematology colleagues recommended the warfarin because we are not sure about the cause of this dilatation, and there is a suspicion of vasculitis, so we choose the warfarin. And after 3 months, we bring the patient back for the relook angio. He reported just anginal pain with exertion, and this is angio after 3 months. The RCA totally occluded. Yeah, same patient. The RCA totally occluded with organized thrombus. All the previous dilatation, there is no changes or an abnormality in the left system, it is like the same the previous angio. So, yeah, so we did echo again. Echo showed the normal LV function, maybe because of collaterals. And we decided to change the warfarin to the DUAC. We chose rivaroxaban because of compliance of the patient. So we closed the case here. The patient remained stable. Just we kept him on the anticoagulant, and he was asymptomatic, and he's on regular follow-up, and he refused any further intervention or even workup. So we close the case here, but we still have an unanswered question. What is the exactly cause in this case? Is it a subclinical Kawasaki disease or something else or something congenital? Would the intervention has a better choice at any point during this course? And if it is it justified to operate on RCA alone? What if the patient needs CABG again in the future? So is the left coronary system at risk of developing aneurysm in the future? And what is the optimal long-term strategy, type, and duration of anticoagulant, especially after the total exclusion of the RCA? So the learning point from this case, huge coronary artery aneurysm with the recurrent thrombosis is rare and challenging condition, especially in young patients without any risk factors. Possible etiologies may not always be evident. Is it a subclinical viral infection during the childhood? Could be potential underlying cause. Anticoagulation alone may not be sufficient, especially in case of large or giant aneurysmal dilatation, as in our case, and there is no clear guideline recommendation for the management of huge coronary artery aneurysm. And thank you for your time.
Thank you.